Hi, Robert Zerfolio from New York City. We're going to talk on part 2 today about proper preparation. And really where I got the idea for part 1 is about segmentectomy. We've now done 612 segments robotically. We converted 2, but we completed 610 of the 612 robotically with 2 conversions, both for nodules we couldn't find. More about that later, but that talks about the difficulties of segmentectomies as when you are not sure that you've resected the nodule. So the preparation for segment is much greater than for lobe. If you're doing a lobe, you can just show up and do it once you've done 3,000 robotic lobes like we have, or 3,000 robotic cases and almost 1,200 robotic lobes. But a segment needs to be thoughtful and prepared. So preparation, preparation, preparation. I'm going to tell you a few new findings in what we're now doing for our segments. This is a great example. So tomorrow we're operating on this patient. All the particulars are blocked so you don't know. And here's the 3D reconstruction. Now all of us are doing 3D reconstruction, but the devil is in the details always. So here it is. It looks like it is an S7 of the right lower lobe. But then when you draw margins around it, which I'm doing now with this blue contrast, the margins are equal to the diameter of the tumor. It's still contained in segment 7. So this is a beautiful case in that it looks everything pointing to the fact that it's just going to be an S7. The new finding that we haven't published or spoke about yet is that when you do the 3D reconstruction, there's an arterial phase and there's a bronchial phase. And those two are sometimes not concordant, meaning the 3D reconstruction on the arterial reconstruction may say it's S7 and S8, but on the bronchus it's just S7. You have to look at these two and get this together. Here's what I mean. So here is the bronchial phase of this tumor. And here you can see your 7, there's your 8 going a little bit more anteriorly. Here is your 7, should be more posteriorly. Here's your 7A, 7B. And this nodule looks like it's contained still in B7A and B7B. Now we look at the arterial phase. In the arterial phase, you can see here's segment 8, here's segment 7, here's segment 9 behind it. So when we get in the operating room, we're going to see the 7, which is always easy to find because it's right where you are converting or completing the fissure between the right middle and the right lower lobe. You'll find the 7, but you're going to see the branch, then you're going to see this branch diving down, and you might think it's the 8. It's not. It's the 7B, and here's the 7A. So we expect to see that in the operating room. This type of preparation makes a huge difference because now you as a surgeon will know when you see that 7 branching that that's not the 8. Now you can dissect it out and figure it out in the OR. I'm old enough that that's how we always used to do it, and I enjoy that. But we should use every advantage we can as an athlete. We're going to look at the films of the people we're playing against. If it's a sport, if it's a football game or a hockey game, we're going to do the same thing here. I have the patient's opponent, the opponent's the cancer, and I have the films here. So I'll know in the OR that will be a 7B, and here's the 7A. And the beautiful thing is they're both concordant that it's going to be an S7 of the right lower lobe. So what is my main message today? My main message today is you want to go to bed and sleep well the night before. If you have a segment and you have a nodule that maybe you can't feel, then you have no way on the back table to palpate the nodule and know you have it. So in this particular case, we're not going to put a fiducial in. We're not going to put a tornado. A quick word about tornadoes and then a final word about wellness and health. So tornadoes are great, but it's another procedure. We love them because they're ICG soaked fiducials that allow you to get in the OR and turn firefly on. You can say, there's the nodule if you do it within 2 weeks because they work well. And even better, they're going to do a cytospin and tell you it's juxtaposed to the tumor. You don't want it in the cancer because it hurts the pathology, but near it. So now you have confirmation it's in the nodule, unlike if you do a Navi-Bronch ICG in the OR, where you really don't know if you're in the nodule or not, and we reported on 200 of those, and we had 10% where we were wrong. That's way too high. I want to sleep well the night before a segment, and this is the way to do it. So if there's a question, if the bronchial and arterial phase aren't concordant, we'll put a fiducial in. If the arterial and bronchial phase are concordant, and it's a nodule I can palpate, then I won't put a fiducial in. This one's 11 millimeters, it's solid, I'm gonna feel it on the back table. So finally, what about wellness? I'm gonna sleep great the night before this segment because I know exactly the arterial anatomy. I know the bronchial anatomy is concordant and they agree. I know when I do it, I can feel it on the back table and I'll get palpable and visual. Don't cut into it. A lot of surgeons like to cut into it. Pathologists don't like that. But you'll get palpable and or visual if you cut into it that you have it. And so I know I'm going to sleep well the night before. And that's what is my final port. We want surgeons who are operating to get a great night's sleep. We want you to wake up with confidence. We want to give you the tools to be able to do that, to wake up and to love your job. If there's anxiety doing these segments that you're going to miss the nodule, and that's the biggest fear of every segment that surgeons don't talk about. They get a little shaky. We all get shaky when things don't go well. Let's prepare the night before the best we can to not only give our patients the best outcomes and the best results, it's all about that, but also we can enjoy what we're doing at the same time. Thank you, Robert Cerfolia from New York City. Looking forward to seeing you all soon.